You are lying in bed. The house is quiet. And you feel it, a thump in your chest, like your heart tripped over itself. A flutter, a pause, then a heavier beat that makes you hold your breath. Maybe it happened bending over in the garden, or sitting perfectly still on the couch. One odd beat, then everything goes back to normal. You blame the coffee, the stress, or simply getting older, and then you move on. One study of nearly 200,000 adults found something that should make you pay attention to that pattern. People who felt this kind of skip often were found to have a meaningfully higher risk of a rhythm disorder called atrial fibrillation, a meaningfully higher risk of stroke, and a meaningfully higher risk of dying from any cause in the years that followed. I'll come back to the exact numbers later, because one of them is particularly striking enough that it connects directly to a test many of you have already had done and forgotten about. Here is the part nobody explains. That beat, the one you felt, is almost certainly not the one that matters most. By the end of this video, you will know what does. Inside Aging breaks down the heart research your doctor does not have time to explain. First, you need to understand why that thump happens, because the sensation can be surprisingly misleading. Once you see the sequence, you'll understand why what you feel isn't always the part that matters. That skip is not your heart skipping. It fired an extra beat, too early, before the chamber had time to fill, so almost no blood moved. Then came a longer pause, while the chamber filled more than usual. That heavier beat you actually noticed is the one that follows, pushing out the larger volume that built up during the pause. The electrical event that started the whole sequence happened a moment earlier, and quietly. Why does it matter more after 60? The heart at 60 is not the heart at 30. The upper chambers enlarge, fibrous tissue accumulates, the natural pacemaker slows. Decades of blood pressure, weight, and sleep patterns have quietly reshaped the electrical landscape. A population study monitored over 1,700 adults 50 and older. Only 1% recorded 0 premature beats over 24 hours. By 70, the rate had more than tripled. Extra beats become extremely common as we get older. What changes is what those beats are a marker for, and that depends on details most people never think to mention to their doctor. Most people assume a skip during exercise is simply the heart reacting to extra effort, nothing more than exertion catching up with you. That is exactly why Frank almost ignored his. Frank was 62, noticed his heart flip only when he pushed his bike up the hill near his house, never at rest, never lying down. He remembers reaching the steepest stretch and feeling the familiar flip again. He'd slow down, wait for it to pass, and keep riding. To him, that felt reassuring. Proof it was tied to effort, nothing more. The fact that it disappeared the moment he eased up was exactly why the pattern was so easy to dismiss. An exercise stress test told a different story. A section of his heart wasn't getting enough blood flow under load, and the extra beats were a downstream signal of that, not the main event. Treating the blood flow problem resolved the skips. Where a skip happens changes what it means. So does when. Susan was 67, retired teacher. A thump in her chest had been showing up for about a year, mostly lying in bed at night, sometimes after dinner. In her mind, that pattern made sense. She was tired, she was still. She noticed her own heartbeat the way you notice a clock ticking in a quiet room. She cut out coffee, no difference. At her annual physical, she almost didn't mention it, felt too minor to bring up. Her resting EKG came back normal, and that normal result did exactly what it usually does. It reassured her. A machine had looked at her heart and found nothing wrong. She went home and stopped thinking about it. Her doctor asked one question that changed the visit. Do the episodes ever wake you from sleep? They did. 2, sometimes 3 times a week. Palpitations that disrupt sleep roughly double the likelihood of a cardiac cause, not the kind driven by stress or coffee. So instead of stopping at the office test, Her doctor ordered 48 hours of continuous monitoring, a small recorder Susan wore under her shirt, going about her normal weekend. The skips were what brought Susan into that appointment in the first place. The monitor revealed something far more important: stretches of atrial fibrillation happening while Susan was completely unaware, including during the night, when she was asleep and had no idea her rhythm had changed. When the cardiologist played back the recording, Susan could see exactly where each episode began and ended on the screen. She hadn't felt a single one of them. The thumps she'd been keeping track of for a year weren't even marked on the same section of the chart. And this is the piece that makes Susan's story possible. The upper chambers can be in electrical chaos, while the lower chambers keep pumping, which means a significant rhythm problem can sometimes produce almost no sensation at all. To understand why, you only need to know two small parts of the heart: the SA node, which starts the electrical signal, and the AV node, which controls how much of that signal reaches the ventricles. Every ordinary beat starts with a small cluster of cells in the upper right chamber called the sinus node, the heart's natural pacemaker. It sends out a single electrical signal on a schedule, and that signal travels down through the upper chambers in an orderly wave, gathers at a relay point called the AV node, and then spreads through the lower chambers so they contract together in one coordinated pump. That's what your pulse is measuring when it feels steady. Atrial fibrillation breaks that first stage entirely. Instead of one clean signal from the sinus node, dozens of chaotic little electrical signals fire at once from scattered points in the upper chambers, many of them from tissue near where the lungs' veins connect to the heart. With that many competing signals arriving at once, the upper chambers never receive one clean instruction to contract. They lose their normal coordinated squeeze and instead quiver rapidly, more like a bag shivering than a fist closing. Here is the part that explains everything about why this hides so well. The AV node, that relay point, still lets some signals through to the lower chambers, so the heart keeps beating and pumping blood almost normally most of the time. The lower chambers are doing the real work of moving blood through the body, and they're still doing it. That's why someone can be sitting on the couch or asleep with their upper chambers in complete chaos and feel absolutely nothing. The pump downstream is covering for the chaos upstream. The bigger concern is what happens inside those quivering upper chambers. In a small pouch off the left upper chamber, called the left atrial appendage, blood can pool and slow down, creating an environment where clots can form. A clot that breaks loose can travel toward the brain. None of that requires a single sensation strong enough to notice. Nighttime mattered for a simpler reason. Some of Susan's abnormal rhythms were happening while she was asleep, when she had no reason to notice her heartbeat at all. The monitor showed that the quiet hours were exactly when something important could be happening without giving her any warning. Susan later told her doctor that the strangest part wasn't hearing the diagnosis. It was realizing that the episodes she had been feeling weren't the ones she should have been watching most closely, and that for a year, the quiet hours had mattered more than the noisy ones. Her case is not unusual. Screening studies find previously unknown atrial fibrillation in about 1.4% of adults, 65 and older. 2 out of 3 of those people were already at high stroke risk before anyone knew. There is one other detail worth mentioning, where you feel the pounding. A rapid, regular pounding felt specifically in the neck, not the chest, points to a different kind of electrical short circuit, 2 pathways firing off each other in a closed loop. If that has ever happened to you, mention the exact location at your next appointment. The location itself is a clue. And some skips arrive with company that changes everything. Richard was 71. He dismissed 2 fainting spells at church as low blood sugar. He hadn't eaten much that morning, both times, and it seemed to explain itself. The second time, he stayed seated in the pew until it passed and drove himself home. It was the third spell, weeks later, that made him agree to be evaluated. Monitoring during that visit, captured a short run of ventricular tachycardia, beats firing rapidly from the wrong chamber entirely. That combination, palpitations with fainting or near fainting, deserves prompt medical attention every time. We've looked at when the rhythm happens and what it feels like, but there's one clue you can't feel at all, and that's where an EKG you may have already had comes back into the story. Remember that study from the beginning, the one following nearly 200,000 adults? Here are the numbers I held back. People with frequent premature beats had roughly 3 times the risk of developing atrial fibrillation, 2.5 times the risk of a first stroke, and more than double the risk of dying from any cause. And here's the number that connects directly to your own chart. A separate study followed more than 3,200 patients, average age 72, and looked at a specific EKG finding, non-specific ST segment and T wave changes, findings that may not point to one particular problem on their own. Patients with that finding had more than double the rate of arrhythmia-related death, 32% versus 15%. The phrase itself doesn't diagnose a heart rhythm problem. What matters is how that finding fits with your symptoms, your history, and the rest of the EKG. If you have an EKG on record with that language, bring it to your next visit and ask whether it was ever evaluated alongside your palpitations. The goal isn't to diagnose yourself from a skipped beat. It's to walk into the appointment with better information. Before your next appointment, do 2 simple things. Keep a 1-week skip diary. Time, what you were doing, whether it woke you or came with dizziness. Then bring it in and ask your doctor 4 questions. Should I have a take-home heart monitor given this pattern? What did my EKG changes actually mean? Based on my risk factors, should I be screened for atrial fibrillation even if I rarely feel it? And which symptoms mean I shouldn't wait for a routine appointment at all? Has a skipped beat ever woken you from sleep? Tell me roughly when it happened. At bedtime, in the middle of the night, or toward morning? I'm curious how many people watching this have noticed the same pattern. If you want more research explained this way, subscribe to Inside Aging. We go through the findings that never make it into a 15-minute appointment, every week.